Hello, hello everybody. Reed here. Today we're going to have a very interesting conversation on the spinothalamic pathway. What's the spinothalamic pathway? This is all the sensory integration, everything that you sense in your body. This is the pathway that accepts the signal and transfers it to your thalamus. Right. This is the pathway that goes from your spine to your thalamus. Right. Um, so we're going to have a very interesting discussion today on the spinal thalamic tract. Let me give it a few more minutes to let a few people come on in, at least one, at least one. You know, you're going to run across patients with severe pain issues, and it's best that you be able to localize the pain or anatomically sort of get a idea of exactly what's causing the pain, and then understand the nerve fibers, and then look at the nerve fibers and see what tools you have to address it. Right. So we're gonna um, so let me see here. So let's go ahead and look at spinal thalamic tract now. If you're new to my channel, please feel free to like, subscribe, and share. Mainly, my channel is more of an education channel, informational type channel. I provide a lot of detailed information about neuropsychiatry and at the molecular, what happens at the molecular biology, at the molecular level to help understand these disease processes and try to treat them. So overall, I'm a psychiatrist and this is my trade. And I'm teaching you how the spinal thalamic tract works. So hopefully it'll be very helpful for you. So on my podcast here, you'll see additional resources. Mainly, if you go to the playlist here, I have things broken down in playlists, on the different subjects. Here, this is the playlist that's going to contain all the different diagnoses and things like that, like how to treat the spinal thalamic tract. And here are like a list of all the medications. So let me see for diagnosis. Let me see which ones we have here. Everybody, so for diagnosis, okay, I have factitious disorder, somatoform disorders. I'm gonna put all the type of things, disorders on this playlist here. Let's see here, in this playlist here, and then questions about medications and things like that. That's what I'm gonna have on this playlist. So you can go to the playlist to sort of see it grouped, or and then I have a lot of other interesting subjects. I'm fascinated with the subject of narcissism. I grew up in I had unfortunately grown up between two different narcissistic family structures and two different narcissistic family systems. And so growing up in those sick environments, I sort of learned a lot about them. It certainly helps me understand psychopathology, personality disorders, violence, things like that. All the people you don't want to deal with. That's what this helps you get an understanding of what's happening. So yeah, if you're here's another interesting thing. And so the series on narcissism is called Narcissism as a Network. Right? When you're in front of that narc is just a receptacle for a receptor for a network, and you're under attack by a network. Then you see narcissistic Black family cults. If you live on the south side of Chicago, I think, listen, you have to understand this concept. Because these family systems are the family systems that's bringing the death and destruction to the neighborhood. It's not everybody. No, it's these narcissistic family, Black cult families and their children who go out and murder and kill and rape and destroy everyone around. And all of us with empathy, we just sit back in silence because we don't want to be the next victim, right? Shut your mouth, right? Quiet, right? No snitching. Snitches get stitches, right? Narcissistic Black family cults ruling the south side of Chicago. That's why if you're on the south side of Chicago, you may want to think about relocating, because I think that the south side is the only access to available resources that the large races and all these things have, the large people involved in our society have to exploiting further. So you're going to see narcissism as a network, as a part of that, talking about narcissism, narcissistic families, narcissistic systems, and things like that. I have other things like diffuse traumatic brain injury, schizophrenia, negative symptoms. I'm just now finishing this series on Tupac as an actor. And this is part 12. And since we got part 12, we're going to produce this as a book on Tupac as an actor coming soon. So we're going to be writing a book. And also, we're going to do an animated series on Tupac as an actor. This series on Tupac as an actor is a part of my Narcissism as a Network series, right? And so this is all the things that happened to Tupac because he was surrounded by all the narcissists around him, right? So Narcissism is a Network. And so the book coming out, Tupac was an Actor by Dr. Reed, coming around real soon. I'm going to show you how this game really works, right? So yeah, join here. I just did this one, the gender war, how narcissists have everybody living in Fortnite, right? Typically, each gender brings the other gender for their problems, but really they're dealing with narcissists. Why? Because normal men and women don't behave that way. So the whole dating scene is controlled by narcissists. And they created a gender war where they have people with empathy you can't find another person with empathy, and you certainly wouldn't get any help from another person with empathy because they sit back hiding. So I think this podcast is very helpful for you guys who want to learn more about neuropsychiatry, psychiatry, the networks around you, and things like that. Did a lot of shorts. I want to also mention here the deadly scams that's happening in Chicago nursing homes. So the South Side of Chicago is inundated with idiots and stuff. And so if you're getting health care, you have to be very careful. So look at my video on this. And so I think it'll be interesting. Now let me do this. I'm looking for so this is on the spinothalamic tract. Okay, let me just see. Okay, let me just look at the spinothalamic tract. Okay, let's hear the spine to the thalamus. Spinothalamic tract, right? The spine to the thalamus, right? Pain. The spinothalamic tract carries pain, right? Temperature, crude touch, information from the body to the brain. First order neurons in the dorsal root ganglion transmit this sensory information to the spinal cord, where the axon synapses with a second order neuron. These second order neurons then cross to the opposite side of the spinal cord via the anterior white commissure. According to the contralateral tract through the brainstem to the thalamus, right? Spine, thalamus. Finally, a third order neuron in the thalamus projects this sensory information to the primary somatic sensory cortex, because this is from the somatic, right? It's the somatic sensory cortex for conscious perception, right? Now, remember, I recently had a patient who we're admitted to the hospital who was having severe pain, right? And it was very important for patients with pain to understand that you acknowledge that their pain is real, right? You acknowledge that their pain is real. Why? When you examine and ask questions about the nature of the pain, the location, and things like that, it does most of the time meet a anatomical area, or it's a reasonable description of pain. And so it's very important in these situations to sort of respect the patient's perspective and to acknowledge that their pain is real. Let me look at this one here, and let me see if I can give you a diagram here. Okay, what is the structure and function of the spinothalamic? Remember, from the spine to the thalamus, right? And then from the thalamus to the somatosensory cortex. Once the traffic gets to the somatic sensory cortex, then you have conscious awareness of the pain or discomfort. Okay, so here, the primary somatosensory cortex, right here, that's the end point. This is an afferent. You see afferent right here, afferent. Let me see here. Afferent, meaning it's going into the nervous system. So let me just track it back from the third order, from the primary somatic, right, sensory cortex. Here, there's the third order to the thalamus. Okay, the thalamus is basically the relay center. The second order, this is the spinothalamic tract, right? Spinothalamic tract. Here, then that's the second order. Then first order here in the ganglion here, and the dorsal root ganglion right here. And then the fiber comes out here. Okay, so these are pain receptors, or heat receptors, or crude pressure receptors, right? So let me just go back there. Since we worked ourselves down, let me just work our way back up. The person we were treating was complaining of intense pain, particularly like in her neck, right? So these pain receptors were being activated, right? The afferent signal went into the system. Now, this is a relay system here. It's the ganglion. This is where a lot of the processing takes place. This ganglion is controlled primarily by norepinephrine, serotonin, and like dopamine receptors too. So the regulatory neurotransmitters are primarily norepinephrine and serotonin. Remember that, right? Because we're going to want to disrupt this ganglion to prevent signals from getting to the primary sensory cortex if we want to treat pain disorder, right? Think about this. A person, think about this whole thing. So let me go through again. The receptors pick up the pain, it passes, and then it's integrated into the dorsal root ganglion, right? By norepinephrine, primarily norepinephrine and serotonin. And then this dorsal root ganglion, it enters here, right? Then you have the crossing over, and then the anterior cord, and on up the spine to the thalamus, spinothalamic tract. And then the thalamus is this relay integration center system. Then the third order neuron projects up to the primary somatosensory cortex. Let me show you what this primary somatosensory cortex, let me just show you that. Look, homunculus. Look here. This is interesting. So this, can I find a video with it? Can I find a video of the homunculus? There it is. Okay. Okay, let's see. Let me see if I can. Will that make it better? Let me see. Well, how do I get that? Okay, let me see if this is larger. Okay, remember in our diagram here, this somatosensory cortex. Now, this is a coronal view of the brain. It's a slice across here, and you take the face off, slice here, and then take the face off, and then you're looking into it. So here's the primary somatosensory cortex. Now, let me show you something here. Look, here it is here, right? Here it is right there, right? And so look here. The lady complained of pain in her neck right here, right? And so this signal is going to, from her neck, the pain fibers are going to be activated. It's going to go through the dorsal root ganglion, and through the dorsal root ganglion, it's going to cross over here, this anterior cord, up to the spinothalamic tract, to the thalamus relay center, on up to the part of the homunculus that's responsible for interpreting those signals. And it's the primary sensory cortex, the homunculus, that helps you identify exactly where you're experiencing the pain or the discomfort. Now, remember phantom pain, right? Remember phantom pain. What if anything along this pathway, look up let me show you in phantom pain. In phantom pain, let's say the limb is gone, so the root is cut off. So let's say in phantom pain, when a person have an amputation, but they still feel pain inside of the amputated limb, right? Why? Because at the end of the nerve fiber is likely scar tissue, is likely other damage to the tissue because it was an amputation, right? And that injury still activates the nerve roots and send fibers. So even though the patient may not have a leg here, because the afferent spinothalamic pathway is still activated by some reason, scar tissue, whatever, the person still feels phantom pain, right? That's that spinothalamic tract here. Let's see here. But this homunculus, let me try to. Okay, let me see here. And then I want to do the homunculus. Let me just show how this works. Blow this up some more. Yeah, look at this on the homunculus. Right. So look at this. Okay. Look, here's the trunk right here. Look, here's the trunk of the body right here. Yeah. Look at how much territory landscape is assigned to interpret the face. Right? Look at that. The face. Right? You ever get pain or discomfort in places that you're not phantom, like referred pain? You scratch here and then you get an ache in your, you scratch here and then you get an ache in your neck or something like that. Yeah, this is the homunculus, and this is the layout of the primary sensory cortex in the areas that interpret the incoming signals. So that's the homunculus. Okay, so here, perception of stimulus. The first order neuron, sensory receptors in the skin detect stimuli like pain, temperature, and crude touch. The nerve endings transmit this information along the axon to first order neurons, whose cell body is located in the dorsal root ganglion. Entry into the spinal cord and moving over to the other side. Dorsal horn synapses crossing the middle line. The axon enters the spinal cord and may travel a short distance up or down in the latissimus fasciculus before synapsing with a second order neuron in the dorsal horn. Right. Crossing the midline, the axon of the second order neuron then crosses the midline of the spinal cord in the opposite side of the anterior right commissure. Right. Ascending the brainstem. Contralateral accent. So it ascends on the contralateral side, because remember, it crosses over here. Once on the opposite side, the axons ascend as part of the spinothalamic tract. They travel through the brainstem, that is the medulla pons and brainstems, in the ventrolateral or anterolateral quadrants. Yeah, I'll show you that a little bit later. Thalamic relay. Thalamic nuclei, the second order nuclei, terminates in the ventral posterior lateral nucleus, VPL, of the thalamus. Third order neurons, they have the synapses with third order neuron, reaching the cortex. Somatosensory cortex, axons of these third order neurons project to the thalamus, out of the thalamus to the primary somatosensory cortex, right? That is the postcentral gyrus, where the sensory information is consciously perceived. So I think we got a really good look on that. Let me push this is even a little bit further. Let me, I'm going to ask, I'm going to try to, let me see. Explain the pharmacological treatment for pain. I'm trying to find how the signaling is disrupted in the dorsal root ganglion, and that's the basis of the treatment, right? So how do you treat these pain disorders, right? Let me show you here. Let me get off the homunculus. I'm done with the homunculus. Okay, what is this? Okay. All right, what am I trying to do now? Okay. Here's what I'm trying to do. Okay. If the signal comes in here, in order to treat a primary pain disorder, we want to decrease the afferent signals, right? So we're gonna have to target this dorsal root ganglion. Remember, the dorsal root ganglion is heavily innervated with norepinephrine serotonergic agents. So we typically give a tricyclic antidepressant. A tricyclic antidepressant targets a lot of those receptors: dopamine, norepinephrine, GABA, glutamate, serotonin. No, it doesn't do GABA. I'm sorry, it doesn't do GABA and dopamine. Sorry about that. Just norepinephrine, serotonin, histamine, alpha adrenergic receptors. The tricyclic antidepressants target all those receptors. So basically, you significantly increase the amount of neurotransmitters like norepinephrine and serotonin in this ganglion, and it disrupts the afferent signals going to the spinothalamic tract. So we want to decrease the afferent signals going into the spinal tract. If we decrease the afferent signals, then that helps decrease the intensity of the pain. So in psychiatry, we don't treat pain disorders, or we're not pain specialists, but we use our tools to help decrease the afferent signals going into the somatosensory cortex. In addition, each pain disorder has two components. There's a physical pain component that comes from damage to the nervous system or whatever created the pain disorder in the first place. Then you have a psychological component, right? And so the treatment in the antidepressants and the medications really go to aggressively treating the psychological component, right? And so let's see if I can get that here. Did I ask it the question? Okay. Pharmacological treatments of afferent pain disorders involving the dorsal root ganglion focuses on managing neuropathic pain, which arises from a lesion or disease affecting the somatosensory nervous system. Medications aim, now, this is the first time I referred to it as disease affecting the somatosensory nervous system. I never thought about it as this cohesive system by itself. I just thought about nerve fibers just running through there, maintaining these responsibilities. Medications aim to reduce the hyperexcitability of the dorsal root ganglion nerves and modify pain signals traveling to the brain, right? That's it. Decrease the hyperactivity in the dorsal root ganglion. Okay, commonly prescribed medications. The initial approach to treating dorsal root ganglion related pain typically involves classes of medications also used for treating epilepsy or depression, which has shown effectiveness in managing pain. The medications used to treat epilepsy basically raises the threshold for action potential and slows the traffic down on all of the networks. So the medications like Depakote, things like that, it slows down the activity the electrical activity, and I think because you're dialing things down, you're further away from that seizure threshold, right? So that's why mood stabilizers and things are helpful for, like the Depakote and things like that are helpful. And then also treatment for depressions, like I said, the tricyclic antidepressants, and because they target a full range of neurotransmitters, you can use that to sort of disrupt the neurotransmitter balance, and therefore the ganglion won't work as well, and so you'll have fewer signals. Okay, gabapentinoids. These like gabapentin, yeah, right. GABA turns everything off. Remember, GABA turns gabapentinoid. The anti-seizure medications calm excited neurons by mimicking the effects of the neurotransmitter GABA. So we also have to give benzodiazepines too. Gabapentin, such as Neurontin, a first-line treatment that causes side effects like drowsiness, dizziness, and peripheral swelling. Lyrica, pregabalin, also effective in improving nerve pain, but with similar side effects as gabapentin. Okay, the antidepressants. Certain antidepressants are effective for neuropathic pain by interfering with chemical processes related to pain signals in the brain and the spinal cord. Okay. So certain antidepressants are effective for neuropathic pain by interfering with chemical processes related to pain signals in the brain and spinal cord. Tricyclic antidepressants. Examples include amitriptyline or nortriptyline. They are first-line agents, but come with anticholinergic side effects and cardiac risk because it targets all of these, even acetylcholine receptors. Next, serotonergic SNRIs, drugs like duloxetine and venlafaxine are also used. Now, duloxetine targets norepinephrine and serotonin, also venlafaxine, which is also Effexor. Duloxetine is called Cymbalta, and venlafaxine is called Effexor. Both of those antidepressants target norepinephrine and serotonin. So basically, disruption of that dorsal root ganglion. Second line and adjuvant treatments. If the first line options are insufficient, others, topical agents, lidocaine, capsaicin. See, I don't like opioids. Let me get off of that. Chronic pain and opioids, let's get off of that. Emerging future pharmacological targeted delivery, monoclonal antibodies, gene therapy. I think that's all we have from there. All right, so I think that's all I have to say so now about the spinothalamic tract. Stay tuned, folks. Tomorrow I'm going to do the cortical. I'm going to do the corticospinal tract. Let me just give you a preview of that. Right. See, from the cortex to the spine, this tract is the primary motor pathway that transmits voluntary motor commands from the cerebral cortex to the spinal cord. So later we're going to go ahead and do the corticospinal tract also. Well, I hope that's helpful for you in your studies, and please feel to. Let me see. See if I got a few questions here. Hey guys, how's it going, iHash? And Ali, how's it going, buddy? Nice to see you again, iHash. I'm doing fine. Thanks for the question, iHash. I appreciate all your questions, bro. How do physicians assess spinothalamic function clinically? See, it's like if they're having pain, it's functioning very well. But as you can see, the pain, many patients can be, it's so extreme, it's so, all the pain is so unbearable. And it's right. It's hyperactivity, it's hyperexcitability in that nerve bundle. And so the only strategy is to disrupt the dorsal root ganglion, right? And also use GABA ergic agents like I stay away from narcotics like opiates and particularly benzodiazepines, but you may have to use the benzodiazepines temporarily while they're in the hospital to start settling down those networks bring Ativan targets GABA. GABA turns everything off, right? So GABA has an inhibitory effect to neurons. So you give them a benzodiazepine that can help them get settled, right? Sounds good. Uh, Next is Al Shah AI Ali. So, hey, how's it going, Asher? Why are you just reading on AI generated things? Um, they seem to, I noticed that the AI stuff seems to explain it in everyday terms. And I have a full range of students, like from college students who are nursing students, medical students, students in the NP, postdocs, other psychiatrists, and things like that. So I have a full range. And so the AI has been very helpful in organizing everything. So I don't have to spend any time on organizing everything. And so this is a very effective tool. And then I'm using all the free resources because I was saying I don't think I should try to make my own diagrams because there's so many free diagrams out here. So I figured I'll go ahead and do it like this. Okay. All right. And I hope that helpful for you guys. Again, like, subscribe, and share. And stay tuned to our next podcast on the cortical spinal tract. Take care, guys. Read out. Take care. Ciao.